increase the Midrodin, which is that medication that we give you for blood pressure control, but up, not down, and to double it, which is going from 5 to 10 milligrams 3 times daily.
3 times daily.
Yeah.
That's about the max, isn't it?
That is the max, yeah.
It makes me so damn tired.
I doubt that the Midrodin is doing that. It's kind of like, Midrodin is kind of like speed.
Oh.
So it's not that. I think you're tired because you're coming off of the prednisone. So prednisone is like the happy pill, right?
Mm-hmm.
It's literally replacing all of the upper in your body. So the upper being cortisol.
Okay.
Right? So you had adrenal insufficiency from your medication you were taking for prostate cancer. It directly inhibits the ability for the body to accurately decide how much cortisol to use and to put into the system. Now, it does this because you have a cancer and they're trying to stop it from growing. Right?
Mm-hmm.
Right.
So it does exactly what it's supposed to do, but the downside is that the body has, we have not perfected the art of delivering medication directly to where we need it and nowhere else. Unfortunately, medications have effects all over the body. Where we want them to have good effects, they do that, but they also have the other effects all over the body, which is the side effect, right?
Sure.
So that's the side effect. That medication stopped.
Yep.
Then they put you on a prednisone to help boost your cortisol. You need upper. So everyone needs uppers and downers, right? You need the dopamine, you need the serotonin, you need the cortisol, you need the vasodilating norepinephrine, right? Those hormones in your body are balanced in normal situations. When we mess with that, with medication, with disease, with whatever, the imbalance we have to try and fix. So they did that. They gave you prednisone. That medication came out of the system, and therefore prednisone needs to come out of the system because now we're overbalanced, you see? And so that reduction, your body is basically going through, we put you on tapers to try and avoid an overt withdrawal, but your body's going to feel less and less happy because we're taking the happy hormone out. And that will cause people to feel drowsy. It will have blood pressures, won't want to go up, and all those things. So we're basically walking a tightrope from one end to the other. What we're trying to achieve is one, allow your body to get back to homeostasis, like get back to normal, right?
Yeah.
But we have not seen an improvement in your vasoconstriction. So when you go from lying flat, gravity is doing all the work, right? Your heart pumps against nothing. It's at the same height as your brain. So you feel normal. And your blood pressures have actually been pretty good lying flat.
Yeah.
As soon as you do that, your heart needs to now push blood against gravity up to your brain. And some people take a while for the brain to for the body to kind of speed up enough to get blood up. But what can happen is your arteries will get tighter to allow an increase in pressure to go up, right? And we measure that in your arm, right? When we do blood pressures. So we have noticed instead of it going up when it needs to, because it needs to increase pressure to get to your brain, right?
Yeah.
It goes down, quite a lot down.
Yeah.
People who do not have blood pressure compensation for positional change like that will feel pretty tired.
It's ridiculous how tired I am.
Right.
So what's with the throwing up now?
Yeah. Well, that's $1 million question. You have a lot of medications on,
Right.
and like 7 of them cause nausea.
Oh.
So the withdrawal from prednisone could be causing it. The positional exertion could be causing it. The lack of oxygen to the brain can cause dizziness and nausea. With positional change, the blood pressure, right?
Mm-hmm.
We call that vasovagal. Many people will get this actually. They're sitting on a chair and they get up too quickly, and they go like, ooh, and they kind of
Right.
feel that's exactly what you're going through. Except it's happening inappropriately because you have more than enough time to stand up, to sit up.
Yeah.
It should compensate, right? It should eventually catch up, but it's not doing that. So
Is that because he's been laying flat for so long?
So that is one component. We do see an increase in vasovagal, which is what I just described, in patients who have been prone for a period of time, or prone or supine. Snipers get it, shooters get it,
Jesus.
athletes get it. Everyone who's been staying for a long period of time flat, the body gets lazy, doesn't need to do it anymore, so it doesn't think about it, and then it just loses its ability. It comes back with physio usually, but you've had almost a week now, right?
Yeah.
And it's profound and it's continuing. So my recommendation is there's a medication we use, midodrine. It's basically a vasoconstrictor. Basically, it causes hypertension. By giving it to you, it should cause your veins to clamp down, your arteries to clamp down, which then increases pressure to your brain, and you should start to feel normal. Now, whether you need this forever or not it's a good question. I don't know. Autonomic failure can do this, like all the disease structures that you've had going on can cause the body to have poor neurological response to positional change. It's possible. The best way to kind of find out is to physiotherapy you, and the best way to do that is to get your pressures up. And so the best way to do that would be to increase the midodrine as high as I can give it safely, with the caveat that you might get hypertension when you're lying flat.
Which is,
The side effect of giving you medication to increase your blood pressure,
what is hypertension?
high blood pressure.
Which could cause a heart attack or a stroke.
Correct. Now, I'm putting hold parameters on. So if you're systolic, lying flat, if you're systolic, the first number is above 160 to 180. 160, they should think about it. 180, they should not give it.
Okay.
Because above 180 goes into stroke territory. The upside, 210, we get nervous about blood pressure in the brain being too high.
Oh,
Okay. The upside is that we have a very easy way to stop you having high blood pressure, and that is to lift you up. Because as soon as we do that, your blood pressure drops. Right? So the risk is minimal, is my point.
Okay.
Sometimes I recommend to fight off nighttime hypertension with midodrine, because I'm giving you medication to raise your blood pressure, right? Is to sleep with your head up. So raise at 30 degrees, increases gravity, reduces your heart's ability to compensate for that, because we know you have orthostatic hypotension, which is what we're talking about.
right.
Means when you change position, your blood pressure drops. So we will leave you at a raised level for sleep to mitigate the risk of having high blood pressures in the brain, because the pressures we see in your arm won't be the same as what's in your brain anyway, right? It'll be lower up here than here because it's the pressure gradient, right?
Yeah. I get it.
Yeah. So that would be the first thing we do, and I'm going to recommend we do that. The other thing is to monitor you closely for elevated pressures, and to give the midodrine 30 minutes prior to physiotherapy, giving it full effect, because it's a short drug actually. That's why we give it 2-3 times a day. It only has a short duration. And we'll try and avoid giving it too late at night, because it also causes people to have trouble sleeping, because it's an upper. It's essentially speeding things up. Right? That's why I mentioned it's kind of like speed.
Yeah.
Right? So with that and physiotherapy, we might teach your body to behave again, and we can then reduce that, because your body will get used to the positional change and start to work the way it's supposed to. If it doesn't, we need to consider that maybe we've done some damage with the other medications, and we need to consider what to do for that. Which I would, once you come off prednisone, you're on a very low dose right now. I think it's 1 now.
Oh, is it?
I have
It was
to
2
double check,
yesterday. 2 days ago.
It could be tapering. I can't remember exactly, but almost nothing. Like 1 milligram of prednisone is like an idea. Not really a big dose. But once we get to the end of that taper, I can then send an AM cortisol which is a blood test to check for adrenal insufficiency, because you shouldn't have adrenal insufficiency now that we've stopped this other medication, right?
Mm-hmm.
That's the whole point of putting you on the prednisone in the first place.
Well, he's been on prednisone the whole time he was on the abiraterone.
Yes, it's to mitigate that. It's to mitigate that.
Okay,
yeah.
and then he's been off the abiraterone, of course,
For a
since he
month.
got sick.
So
2 months.
Right. Sorry, 2 months. So you shouldn't have adrenal insufficiency is my point.
Okay.
But people can develop adrenal insufficiency on its own. So what if the medication triggered an adrenal insufficiency pathway that is not rebounded, and now we've tapered him off prednisone, and that's why we're having drops in pressures, that's why we're having the nausea, the dizziness, right? That's maybe why. So I'd like to get to the end of the prednisone taper. I don't want to stop it early because it's important for you to finish the full course. Once we've at the end of that, we have to wait for 48 hours after prednisone, because testing you for cortisol with prednisone in your system is useless because you have cortisol from prednisone. But you should have a certain amount of cortisol naturally in your system that prednisone is not doing anything for, and the only way to test for that is once you come off the prednisone. So then I'll send a blood test for AM cortisol, which is what you probably have done in the past. I'm sure you've done one. No? Either way, we'll do the test, and if the number is low, meaning you don't have morning cortisol, then we need to consider why. And there's a lot more to that pathway, probably above my pay grade. But I can definitely send you to the right person.
Okay.
Who is?
It would be an endocrinologist.
Our oldest daughter is a nurse,
Okay.
and she was talking about Sunnybrook, having just a consult with Sunnybrook because they have a very intense program there for hypotension.
For orthostatic hypotension.
Mm-hmm.
So let's get down the road first before we start figuring out what we need.
Okay.
We could solve this with Medridin and physiotherapy. Done.
That would be great.
It would be great. So I'd like to give that a try.
Now, how long do you... He's only been, is this his 4th day on 5 milligrams of midodrine?
I think it was increased early last week, but it should have had an effect by now.
See, he's okay now. He got up today. Well, I mean,
Yeah.
it dropped at the end, right?
Still having nausea, still having quite profound drops in pressure. So I would have liked to, so technically if we give this medication, people should, like, I don't feel dizzy when I sit up. They should be saying that. If they don't say that, then I wonder if it's working.
Mm-hmm.
Or if we have enough in the system.
I see.
I'm going up because this morning your pressure's dropped the same amount as it's always dropped. Now you might have felt a little bit better because the midodrine was in the system, but it just tells me that the midodrine might be working, just needs a bit more oomph.
Okay.
And if we can get to that point without, too much concern as far as a high blood pressure when you're supine, we're winning, I think. And the nausea will likely get better if my theory's right.
The what?
The nausea.
Yeah. Oh, that'll get better.
Yeah.
And
It should. Yeah.
How long do you think?
Well, we'll know pretty quick. I mean, midodrine tends to, as soon as it's in the system, it does the job of what it's supposed to do.
Like when I do throw up, it's bang, I'm throwing up.
Yeah,
But
it's like
there's
sudden.
No warning.
Yeah. Any blood? Any?
No.
No.
The last 2 times has been lunch and supper.
As in this lunch and last supper. So you tolerated breakfast in between?
Yeah, I don't, because I'm not a real breakfast guy.
Oh.
I don't eat a lot.
He just eats some yogurt and some coffee.
So that might be your first problem. You're taking some significant medications that require food.
Okay.
So let's eat a breakfast. Okay, a good one, specifically with fiber and things to kind of gum up the system a bit.
Okay.
But they don't give him a whole lot of fiber because he's on a renal diet.
Right. Okay, fair enough. Whatever amount of food you can put in your belly in the mornings, it's going to serve you better when you take your pills. Don't take your pills unless you've had some food in your system.
Yeah.
There are some pills that require no food in the system. I'm not sure you're on any. I would have to double check that. The nurses would know.
And he's not been eating enough, I don't think.
Right. So that's
Well, God, it said where And water and Jello for how long?
I know,
So your stomach is a bit slow to recover.
Yeah.
Yeah. So go slow. I'm with you, but you know, you jam these kinds of medications into your stomach that barely has anything in it. It's going to make you feel pretty nasty. Are you on a medication to protect your stomach, Pantaloc, or
I don't think so.
maybe?
they talked about that before, though.
What's up?
Is that to make you feel like stop nausea?
No.
No?
It depends on what's causing the nausea. It sometimes can stop nausea if it's
Okay.
to do with stomach acid.
I
Um,
don't know. Maybe.
But I'll look. If you're not on Pantaloc, I'll throw you on some. And it's basically it's called PPI, a protein pump inhibitor. It just basically reduces the amount of acid in your stomach. Sometimes it makes you feel better.
Okay.
We gave you the good stuff for the nausea, the Zofran, right?
Yeah.
And it does
Yeah.
work, I was told.
Yeah.
Okay. Have they swabbed you yet? They stuck a swab in your nose to see if you're having a virus.
Yeah. They did.
Only when you first came in.
Okay. Well, if they haven't done it with this new run, is the nausea just been all along, or is it kind of new?
It's
Kinda
pretty new.
blue.
Yeah. Well, I'll swab you. How's that sound? I'll swab you to see if maybe you picked something up. You know, it could just be a viral thing. If that's negative, we'll give you the Pantaloc. Try that. Eat some food in the mornings before you take your pill. We'll try this new medication. Well, an increase of the current medication. If you're saying you're having some symptom relief sitting in a chair, because you weren't able to tolerate that at almost all, right, before?
No.
Right. So if you're having some symptom relief, that tells me that Midrodin has done something, and more of it might help. But again, we need to balance that with the risk of blood pressure being too high.
Mm-hmm.
So, welcome to my world.
Mhm.
It's just, I don't.
Yeah, we walk a tightrope, and that's fine. We've done it many times. I'm confident that we've got a plan here. We just need to give it time to get going. Does that sound fair?
Yeah, just, I'm an inpatient patient.
You also are an inpatient patient. That's fair. What were you doing before this whole journey?
Everything.
Pretty independent?
Oh,
God,
yeah.
Yeah, I was shoveling snow, blowing snow.
We
Yeah.
just came back from Dominican.
Oh,
We were down there for 10 days.
when was that?
In January, we were in Dominican.
Did this happen right after that?
I had a turp right after.
He had a turp on the 3rd of March,
Right.
which led to this, because he was all plugged up with blood clots in his
Yeah,
bladder. I couldn't flush him anymore, and
right.
that's where that came from.
Mm-hmm.
And then they brought him in here to get a catheter put back in, and they couldn't do it. They had to put him into surgery to do
Yeah.
that.
Yeah.
And then he turned septic through the night.
Right.
But before that, we play euchre every Wednesday. We're
Right.
cleaning out our driveway, we have a 96-year-old neighbor, we clean out her driveway, we clean out her
Do a
sidewalks,
porch and stuff.
take out her ashes.
Take her ashes out.
She burns wood, she's 96 years old.
You live long when you're out.
Yeah.
I'm appreciative of your situation. I understand it's a bit of a journey. But if you let yourself get too overwhelmed with the whole thing, you got to set small attainable goals. Okay?
Yeah, oh, I'm gonna beat it, I'm gonna beat it.
Yeah.
I know damn well I'm gonna beat it.
But he's saying we got to take baby steps, I think.
Yeah.
Is that what you're saying?
Yeah, so have you ever done any mental resiliency? Have you ever read about that? Do you know what that is? Mental resiliency? No. So I was in the military for 22 years, and they teach this to the soldiers, and it does work. And I find that
Right.
sometimes it's helpful for patients in your situation. Okay, you got to set small, attainable goals. So, and you don't worry about getting out of here. You don't worry about the end, the mountain, right? You look at the small segments of the journey, and you achieve those little segments. And as you make little gains and wins, you stack wins on wins, and then you look back and you're significantly further down the road. what can happen is people get pretty down. I mean, it's not the most beautiful building, and not the most beautiful patients that are roommates, and not the most beautiful situation that you're in. I get that.
Right.
But if you get overwhelmed by that, the amount of cortisol in your system, like you have a direct problem with cortisol. Cortisol is stress hormone, right? You don't have enough of it, and or you have too much of it, it's not going to go well. So you need to try and find that peace, that resiliency, to keep working with physio, getting up every day, doing your very best to push through the nausea and get through physiotherapy. Obviously with blood pressures in the toilets, that's not helpful. You can't will your way from that, but I'm going to help you with the meds. Okay, that's going to work. I have confidence. And then, you know, you look back in a few weeks and you're further down the road than you were now. And if you stick with it, you know, this does get better.
Yeah.
Especially if this is what I think it is, which is the most likely cause, is that you've just had a pretty serious health concern and the body takes time to recover.
Mm-hmm.
And the autonomic system takes time, especially when you've been on your back for a period of time. Because you haven't been walking since the TERP, correct?
Since the TERP, yeah, 2 weeks up. The TERP was on the 3rd of March. He didn't get sick till the 18th.
Okay, so since the 18th of March, you've really been bedbound.
Yeah.
So if you do the math on that, so for every day in bed, we know, and anyone above the age of 70, 1 day in bed takes 5 physiotherapy days to get back to the level of strength you were the day before.
Jeez.
And if you have spent even a month in bed, do the math on that. It's exponential, right? Now it's a crude measurement, and I've seen people go home in 2 weeks. So
Right.
it's not always the case, but that is the expectation, to at least give you a timeline of what the worst case scenario could look like,
Right.
Okay.
right? Whereas, you know, with your mental resiliency, keeping yourself going, working with physio, pushing hard, getting through those things, and support from the medical team with the blood pressure and so on and so forth, you know, could be better than that.
Okay.
And then if your daughter wants me to do a referral to Sunnybrook, I would first of all need to prove that we have failed here,
Yes.
because Sunnybrook doesn't just take people.
No.
They need to take specific cases, unless your daughter has an in.
Don't know that she does. No.
So, you know, we'll hammer on the plan.
Okay.
If I get to the end of the rope and I have no more options, then I'll definitely, you know, take you up on your suggestion. Let me know if you want me to go sooner. I can always send it as a second, what they call that, second opinion. We can send for that. Whether it's successful or not is really not, I won't know for sure, but we can always do that if that's what you want.
So, when you're trying this, what are we talking about? How long before we suggest doing something else? You'd see a difference in a week, 2 weeks?
So it's very variable based on why we're having trouble. Right now it's blood pressure and nausea.
Yeah.
We have a plan for both those things. I expect them to get better.
Okay.
If I'm not seeing improvement by next week, I'll have another plan. We have another drug called Florinef, which is used as a steroid.
I know.
It actually helps both the, you know, it won't be prednisone, but it's like a steroid in many ways. So it could do a dual thing. But I don't want to commit you to a steroid for life, so we're trying the Midrodin first.
Yes.
To see how that goes. And we're maxing it out. So I expect to see some improvement.
Okay.
Being the fact that with just half the dose that I'm about to prescribe, 5 milligrams 3 times daily, which is what he's on for the last 4 days-ish, there's been some improvement. Which means that if I give more of this, it likely will have another round of improvement.
Okay.
And then just got to balance it with the risk of high blood pressure. For now.
I know.
So when we talk about high blood pressure, there's 2 things we're worried about. There's the 10-year risk factors, so that's long-term hypertension, right? So we're talking strokes and heart attacks from 10 years down the road. And then there's the most immediate concern, which is the acute risk that can happen with hemorrhage in the brain from too high of a pressure in the vessels in the brain, right? That's at 100, that's at 210 plus. Sometimes I've seen it as 280 or more. So we have lots of space, is my point, okay? That one we're worried about now because, 10-year risk factors of not getting out of bed significantly more risky than hypertension.
Yes.
Right? So we are dealing with risk benefit right now. We're saying getting up and moving, getting back to your independent life, we can deal with the blood pressure later. We're making that call so that we can get you moving, get you physically fit, and I suspect as soon as you start to move, eat properly, sleep properly, these things will start to improve, your mental health will improve, your physical function will improve, your blood pressure will drop on the medication, but it'll also come up when you sit up. We'll pull back on the medications that make it high blood pressure, and we'll be done. That's what I think is going to happen.
Okay.
Okay.
What are you thinking? Information overload? And the extreme fatigue, is that post-sepsis syndrome stuff?
So, major surgery, sepsis, on the background of prostate cancer.
Oh yes, all last year he was terrible tired.
Yeah. On the background
medication.
of adrenal insufficiency with medication for prostate cancer. On the background of withdrawing from prednisone. Right?
Jesus.
So
There's
very
spots,
good
there's
reasons.
6.
Very good reasons to be tired, nauseous, and dizzy.
Okay.
What we've got to do is get you past that
Yeah.
and just deal with what we can deal with. Like, deal with what we can actually do something about, which is your blood pressure and your physical function.
Yeah.
I expect once we've done that, things will improve. It'll be a global improvement. I do think a global improvement will happen. We just got to get you past that point.
Yeah. It just
And,
seems like a long time getting there.
Yeah, but if you think about the timelines, we're really on the front end of it, and it's only as long as one, the medication takes it. So, in a perfect world, my plan here is going to work, right? And I do have confidence it will work. I've seen this many, many times before, and many, many times it's been treated with this medication.
Okay.
So, in a perfect world, my medication works, then it's going to be up to you. You work as hard as you work, is as quick as you get better. Obviously, within reason. We don't want you pushing yourself to a point where you're not safe.
Right.
But I suspect that won't be the case. I think we'll find a happy medium, and we'll get you there.
Sounds good.
Okay?
No, I know that this plant, like this course of treatment is fairly new, but I'm saying for us it's been a long time. Like from the time he's been sick, from the time he got diagnosed with cancer, all of it, it's been kind of
Yeah, I'm with you. But what I'm trying to say is if we can refocus from seeing it as a global thing, seeing it as small little things, it helps with the timeline.
Don't look at the big picture.
Yeah, because the big picture is kind of daunting, and it's super depressing if you look backwards, right? I'm with you there, and you have every right to feel that way. I'm just suggesting for a small moment, if we can just set small attainable goals, and we'll achieve those goals, and we'll stack up success, and we'll be okay. We'll get through it. You'll get back to your life.
Yeah.
Because it can be overwhelming, when you think about what you've gone through, over the diagnosis of cancer, then this whole the TERP, then leading to sepsis, it can be overwhelming. But that sense of overwhelming is not going to be helpful in rehab. In my experience, people who are feeling down in rehab don't progress as fast as they could. So I'm just giving you some encouragement to consider looking forward, setting small attainable goals. So the first one could be tolerating my breakfast. Right? That's as simple as it is. Tolerate my breakfast.
Yeah.
All right, I didn't tolerate it today. Okay, I'll try and tolerate lunch. Okay, I tolerated lunch. Excellent, that's a success. What worked for me? This worked, that didn't work. Last time I ate that, it made me feel sick. This time I ate this, it made me feel good. I want to eat more of that, eat less of that. That's the kind of thing. Stack those little successes, and you'll look back in a week, and things are going to be progressing. Then you look back in 2 weeks, and things are going to be progressing. Whether you're here or somewhere else, that is the way to stack success.
Okay.
Okay.
Yeah.
Okay. Now, if you want me to take down my number, I have my extension.
Okay.
So, I'm not sure if I introduced myself. I'm sorry. I was in another meeting I ran here. My name is Seth DeFlorio. I'm the physician assistant. So, I'm the PA.
Sorry?
The physician assistant, the PA.
Yeah.
Sorry, one
Mm-hmm.
second. So I work with doctors,
Mm-hmm.
and when you're on rehab, the doctors change every week, right?
Yes.
So I don't. I'm 9 to 5 every day.
Okay.
Other than weekends, obviously. And so I get to know the families. I get to, where's my, here. I get to know the families and you know, because doctors change, you know, when patients are on rehab, they tend to be here longer than a week. That's why I'm here, just to make that continuity between.
Oh, that's good.
Yeah.
I like
Yeah.
that. Yeah.
Okay, and then you know me, and you don't have to chase down doctors and try and get a
Okay.
new plan. And then every time they come in with a new plan, and
Okay.
it can get frustrating.
All right.
So my name is Seth DeFlorio. I'm the PA. My number is 3899. That's the extension to my office.
Mm-hmm.
I'm very rarely in it, so please leave me a message.
Okay.
And within the week, I will call you back. Most often within 24 hours.
Okay.
And then I'll try and answer any of your questions if you have any concerns. I'll do my best, and you'll probably see me weekly. If you see me more, that's not good. See, about a week-ish. If things are going well, I'll pop in and say hello here and there. Most of the time, the medical stuff is sorted out when you get to me, but you are a little bit different, so we'll work on those meds and check in and see how you're doing. I do check in with the nurses every day, so every day I'm getting a report on everyone on the unit, so I am, even though I'm not physically here, I am following things.
Okay.
But again, if you need me, just say something and I'll come say hello. Okay?
Thank you so much
You're very welcome.
for coming to see us.
You're very welcome. Sorry it took me so long.
It's okay.
Good to see you, good to
Thanks,
meet
Seth.
you. I think you'll be fine, okay?
Thank you.
You're gonna have that chronically?
No.
No.
They put it in post-sepsis?
They put it in post-terp, and then it came out because he had blood clots,
Yeah,
and then they put it back in because nothing was flowing,
right,
and
And
that's
urology-
made his kidneys unhappy.
right. So urology, are they involved still?
Urology, you don't have a neurologist here, right?
We do, well, it's very new, but we have 2 urologists that are sub-regroup that are
Sadat?
coming. Sadat is not one of them, unfortunately.
Oh, okay.
But we do use Sadat. We send people to Sadat.
Okay, but that we don't have one here.
We have Dr. Reed, who comes here,
Oh, he comes here?
and we have Dr.
McDonald.
McDonald, and then he also comes here. But that's very new, over the last
Okay.
month or 2.
Okay.
So they're setting up.
Well,
they're
his-
setting up a dual practice.
It was
Dr. McDonald did his terp.
Okay, perfect. Okay. Do you have a follow up with him?
Well, we did, but we passed that deadline.
Right.
Yeah.
I might reach out and have a chat with him to see what we want to do with this, because catheters aren't great for physio.
Yeah.
But until I can walk, what am I gonna do?
So we're building success, right? So that involves
Yeah.
starting to use urinals and, starting to build an independent life. So the more tubes we have in us, the more someone does something for us, the less we do for ourselves. And that includes tubes doing the work, right?
Yeah.
The less likely you are to get to independence. So we want to try and model independence, right? So
This catheter was put in April 7th.
is it a silicone? Do you know?
It was supposed to be like a harder one that wouldn't collapse when they tried to aspirate.
Okay. So I'm not going to be playing around with the post-terp, urosepsis patient's catheter.
Mm-mm.
Don't get me wrong here. But I am going to call him and see what his plan is, because if there's a plan to take it out, maybe we could do it here.
But it was done in Sudbury, this was put in.
Mm-hmm.
Is it a suprapubic or is it in the penis?
No, it's in the penis.
Okay. So let me have a chat with him and see what his plan is, because if we can initiate it here, part of the rehab program,
Yeah.
good.
If doctor comes right here, then that's
Yeah.
great.
Okay. So
Yeah.
I'll look into that as well.
What are you thinking?
Well, this one was put in Sudbury
Yeah.
because the other one just continuously plugged, and that's when they put me under and did the whole scrape and
Yeah.
everything.
Uh-huh.
Yeah. But is that considered a chronic issue? Like, do they expect that to be a problem all the time?
I don't
'Cause
think so.
Usually that's a
The-
resolution.
The turf was supposed to fix it.
Right. So that resolution is a plan. Likely means that the catheter doesn't need to be in forever.
Right. Oh, no.
Yeah. So I'm going to try and figure out when that duration is, and I'm just giving you a heads up. I'm going to try and take it out if he's fine with that, and that'll start to build you into your success of rehab, of trying to build that independent life.
Okay.
Okay.
That
All right.
scare you a little bit?
Yeah.
Yeah, and that makes sense because I mean, you've been rocked around with your bladder recently, so.
Well, yeah, because they did a trial, a void in Sudbury on the
Yeah.
6th of April,
Right.
and they had to put it back in on the 7th
Right.
because it wasn't going.
That was post TERP.
Oh gosh, yeah, that was his turf was March the 3rd. This was April the 6th.
Right. So TERP swelling. So it's not unusual for people to have catheters post TERP because of the swelling inflammation.
Yeah.
There's blood in the bladder. The little clots can bung up the works
You know they put 115 bags through him.
of flush.
Yeah.
CBI.
Yeah, I believe it. I don't like CBI. CBI is the same size tube, has 3 tubes in it, right? They're not all like connected. They're just jammed 3 tubes, smaller tubes into a big tube, and then they push it in. So those little tubes don't accept clots very well because they're small, right? So I use a 2-way, which is a much bigger diameter, just 2 pipes going into the same pipe, right? A much bigger diameter, and I flush. We just
Manual
manually
flush.
flush them, and it works. In my opinion, works way better than CBI.
That's
So,
what they did in Sudbury.
Okay.
CBI.
Right.
He was full of clots.
That being said, we're not seeing any signs of clots right now.
We
which
were
likely
Sunday
means-
though, eh? You heard that?
Yeah, I heard. Yeah. So, but likely we're seeing less inflammation from the TERP. We're seeing less clots in the system
Yeah.
because it's cleaned out. The swelling around the bladder neck is likely reduced because it's been a month and a bit post.
So we expect it has, yeah.
Yeah, but we got to make decisions based on the likelihoods of things.
Yes.
Otherwise, we won't ever take the catheter.
I know.
So, yes, there's risk that may not go well, but let me phone him first and see what his plan is. He might want to keep it in for 6 months to give it some time to heal. He might say, why is it still in, right?
Yeah.
So let me find out. But I wanted to at least clear that on the front end so that you're not getting surprised by it later, okay? Make sense?
Mm-hmm.
Okay. Do you have any other questions or concerns?
Oh God, I can't. Everything with the medicine and pills and now this, like, need a break.
Just try not to worry about it all. Just do what you can do, is eating and drinking as much as you can, and
Yeah.
do your part, and they're doing their part, and that's all we can ask.
Sorry for freaking you out. I was trying to help you.
Jesus.
Do you want me to circle back around tomorrow, so in case you have any secondary questions, so you can have some time to process?
Not if you're that busy, no. No.
I'll make the time if you need me to.
We'll just work on eating and drinking and
We'll see what next week. Let's go with the plan.
Yeah.
And let's see what we're looking like a week from now.
Perfect.
All right?
Yeah.
Okay.
Okay. Thank you.
Thanks, Dad.
No problem.